Welcome to today's lecture on the routine examinations of the ear, nose, and throat. Today, we focus specifically on the ear. Routine examinations mostly lie in the application of special instruments, together with the simultaneous use of artificial illumination. Generally, the examinee and the examiner take the sitting position, facing each other. Infantile patients should be fixed by a parent or nurse. The light source is placed at the right posterior side of the examinee. The examiner wears a frontal mirror to focus light on the examined part. First, let's discuss the examination of the external ear, which includes observation and palpation. The examination is to observe the skin color, flexibility, and mobility, checking for swelling, laceration, or congenital fistula. Palpation finds tenderness or lumps. A probe can test lump hardness, while pulling the tragus identifies inflammation. An otoscope is needed to examine the canal and drum membrane clearly when the visual line is blocked by trachea or earwax. For adults, the upper part of the auricle should be pulled postero-superiorly, up and back to straighten the canal. For children, the lower part of the auricle is pulled postero-inferiorly, down and back for clear observation. The examination of the drum membrane is of great clinical significance, especially observing the flaccid part. Normally, it is grayish-white with luster, whiter at the edges, with a reflection cone of light on the antero-inferior part. In myringitis, luster and the cone of light vanish, often replaced by congestion, pachinsis, or calcareous deposits. Pathology changes position. In hydrops, the membrane appears umbonate. In eustachian obstruction, it invaginates. We must note the position and size of any perforation. Traumatic ones are irregular and fissured. Marginal perforations in the flaccid region indicate serious changes, often accompanied by odor and cholesteatoma. A pneumatic otoscope checks mobility. Squeezing the balloon moves the membrane, while adhesion prevents movement. Ventilation tests check if the auditory tube is unobstructed by squeezing air into the tympanic cavity. Self-inflation involves clenching teeth, holding nostrils, and blowing air until a booming sound is heard in the ear. Mechanical inflation uses a rubber balloon during swallowing, or a metal catheter for even greater pressure. Audiometry determines the degree and nature of hearing loss, which is vital for diagnosis and treatment. The phone test uses whispering from 6 meters, while the distance test approaches with an audiometer until sound is heard. Tuning forks at 256 or 512. Hertz discriminate the type of deafness via Rinnes and Weber's tests. Schwabach's test compares bone conduction to an examiner, while pitch tests determine low and high limits. Electric audiometers accurately profile conduction, nerve, and mixed deafness across various frequencies. Finally, vestibular function refers to balance. Dysfunction manifests as nystagmus, vertigo, and dumping. Nystagmus consists of fast and slow phases, graded in 3 degrees according to the severity. The spontaneous dumping test and deviation orientation sign help identify vestibular pathological changes. Induced tests include caloric, rotation, fistula, and glycerin tests to further diagnose vestibular issues. This concludes our systematic overview of ear examinations. Thank you for your attention.